Atopic Dermatitis 360, Real-World Strategies to Improve Outcomes. Ages 6 to 18, mild to moderate. I'm Dr. Lawrence Eichenfield. I'm a professor of dermatology and pediatrics and vice chair in the Department of Dermatology, chief of pediatric and adolescent dermatology at Rady Children's Hospital, San Diego, and University of California, San Diego School of Medicine. This program is approved for 0.5 CME, CNE, CPE, and AAPA credit hours. You can download a PDF of the presentation under the Event Resources tab on the left side of your screen under the headshot. You will be directed back to the landing page after the webinar to complete the post-test and evaluation. You can then download or print your certificate. The program is provided by North American Center for Continuing Medical Education, LLC, an HMP Company, and this program is sponsored by an educational grant from Pfizer. The learning objectives are to discuss atopic dermatitis treatment approaches specific to ages 6 to 18 for mild to moderate atopic dermatitis. Let's start off by looking at the epidemiology of childhood eczema. So this is a world view on the atopic dermatitis prevalence, and this is looking specifically at 2 to 11 years of age. So our discussion today is really sort of 6 up to just about 18. And you can see that at 2-year-olds, the United States has about a 10% prevalence, and there is some variation around the world in this large internet-based service. If we click over to the broader 0 to 18, we have 9% prevalence. So basically, we know the first few years of life has the highest prevalence of atopic dermatitis, and then there's a little bit of decrement. But when we're talking about the 6 to 17, almost 18 age group, you still have a very high rate of atopic dermatitis, some of whom presented as very young children and have persistent atopic dermatitis, and others whose disease has developed later in childhood. And this is one of the interesting things that was brought home by this great study, the Paternoster study, which was basically looking at a birth cohort over time and showed that there are various disease trajectories. So first it included patients who had sort of transient dermatitis. That's the line in green, but ignore that line. But then you see that there's a mid-onset atopic dermatitis, starts in mid-childhood and then resolves over time. And then there's a later onset resolving atopic dermatitis. And then there's our classic in purple early onset that then resolves by 5 to 6 years of age. But there's also a early onset that persists over time and an early onset that resolves late. So it's an oversimplification, I think, that atopic dermatitis starts in young childhood and then goes away. And certainly when you're dealing with our 6, 7, 8, 9, 10, 11-year-old, many of them will have persistent atopic dermatitis from early childhood, others later onset disease. And our adolescents generally, most of them will be persistent childhood atopic derm that's heading into adulthood, while others will be newer onset. The risk factors for persistence into later life include age older than 4 years of age, at the onset of the, patients who are at least 4 years of age and had onset at infancy, or onset after 2 years of age. So in dealing with your 6 to 18-year-old, you very quickly can establish, was this early onset and they still have their disease, so they're already in a group that may be persistent, may be heading to persistence into adolescence and adulthood. If their onset was after 2 years of age. Parental history of atopy also is a higher risk factor for persistence of disease. And of course, the more severe the disease, the more chance it's going to be that there will be persistence over time. Now, diagnostic features of atopic dermatitis you're very familiar with. We have pruritus, we have the eczematous lesions, but also the age-specific patterns. So particularly when we're talking about our 6-year-olds up to adolescents, you're basically going to have the pattern between childhood and adult. You'll have antecubital popliteal fossa involvement very commonly, often neck involvement and facial involvement as well. Once you start to hit the adolescence, it's very common. You can get hand involvement as well, and hand eczema should be something that's particularly looked for. We know the clinical features, in other words, are pretty constant across these years, but of course, the bigger differences are going to relate to the extent of the disease and the severity of the disease, because that and the persistence can be highly variable in this population. We should note the clinical findings can include Ichthyosis vulgaris. That's important in terms of registering the degree of the xerosis and dry skin that may be part of our management, as well as lichenification and the erythema of eczematous dermatitis. So in evaluating children with atopic dermatitis, of course, you're trying to get a sense of does the disease look like eczema? You want to review the personal and family history of eczema, as well as xerosis and dry skin. Neonatal onset, so in other words, if I have an 8-year-old who's presenting with new onset atopic dermatitis, I would like to know if it's a new onset in the last few years, or if they started as babies. And then, of course, other atopic conditions which both impact on the disease and on the family and are associated and may require management. I try to examine the current symptoms, how bad are the rashes, itch associated with the rashes, the primary and secondary findings, and then, of course, it's not just what I'm seeing that day in the office, whether the disease is intermittent or if it's very persistent, is, I think, very helpful in terms of getting a sense of the severity. The disease assessment is rather interesting in this population, because you know that if you look at a categorization standpoint, this is actually looking at 0 to 18 categorization in a big prospective question-based survey by Jonathan Silverberg. You can see that about 2/3 of childhood to adolescent atopic dermatitis is reported as mild disease, 26% as moderate, and 7% severe. So here we're emphasizing mild to moderate disease, which is the vast bulk, but then there's this overlap to moderate severe disease, which we'll discuss further in a different talk. But how is it that you go on and decide whether a patient is mild to moderate or moderate to severe? And my takeaway is that assessing severity in clinical practice is very different than in clinical studies. You know, in clinical studies, we have our standard tools. For instance, we use the EASY score, the Eczema Area and Severity Index. I know that this score is hardly ever used in clinical practice, okay? But it's a score that gets scored up, 0 to 72, and then there are these bands that would define moderate to severe disease. So if you have a score of 0 to 7, you have mild atopic dermatitis, and moderate 7 to 21, severe 21 to 50, and the very severe is 50 to 72. Most people will not use this in clinical practice. It takes about, if you're really quick, about 5 minutes to do a score, but if you're not doing it all the time, it's 10, 12 minutes. We generally not something done in clinical practice. The SCORAD's also done in clinical studies. That basically is, there's an objective SCORAD, and then there's a SCORAD that includes questions on itch and on sleep. Again, it's a scoring system used in clinical trials. Other things we use are the POEM, the patient-oriented eczema measure, body surface area, and then quality of life scores. And we'll go through that later. I actually think that assessment of body surface area is something that's not something that's bad to do, but generally, severity practice in clinical practice is gestalt. So, or what I wrote down here, the UOIGA. That's the unofficial IGA, meaning you look at what you're seeing that day and get a sense of what's happened over time, and you can say, boy, this patient's pretty clear, this patient's almost clear, this patient's mild, moderate, or severe. And I think that assessment, which is really trying to look at the qualities of the eczema and the extent of the eczema, is highly reasonable. So what do I do in my clinical practice if in assigning, a category? It's going to be the extent of the disease, how much disease is there on the skin. the severity of the signs of atopic dermatitis, the qualities of the eczema. Is it oozing? Is it crusting? The degree of redness? Are there excoriations? The symptom severity, how bad is the itch and how bad is the sleep disturbance? And then the disease course, which is really the surrogate for quality of life scores. I always ask, when's the last time the skin was totally clear of eczema? I think that's really important. A question, and then I'm trying to get a sense of whether it's something that's there all the time, which in about 40% of my patients it is, but of course I have a selected patient group, or if it's something where it comes under control. It may stay under control with moisturizers for for weeks or months at a time. The older we get, the more chance that patients may be more persistent, it seems. But there are a variety of factors that will influence this. And then the life impact is really how much it's impacting the individual. I'd like to do a shout out to measuring body surface area as something that can be really helpful in assessing the disease severity from visit to visit. I've started to do what I call Gestalt body surface area. Well, technically the palm being 0.5% is the most consistently reliable. I basically use the child's hand as 1%, and that hand size area on the body is 1% body surface area. And in this age group, it's actually pretty easy. And while I have on this slide the Lunda-Brouwer score to be more detailed, generally, if a patient's got 18 hands of eczema or less, it's pretty easy for me to look. If they have antecubital fossa bilaterally and popliteal fossa and not much else for the milder disease, and I measure up, boy, that's about 5 hands in total. That's going to be 5% body surface area. And so that 0 to 18 or 80 to 100% is pretty easy, 50% is pretty easy, and you can Gestalt in between. I think it's something that can be helpful to assess the eczema. Now, we're trying to assess the severity because we know the impact of the disease. Now, I'd like to read this. This is sort of a summary of the impact of atopic dermatitis, which really pushes our desire to treat. So starting at 9 o'clock, that's the eczematous rashes, and that's tied in with the signs and symptoms. And if you move up to 11 o'clock, we have the symptoms, the pruritus and intense itch. Sleep disturbance clearly impacts on the individual, impacts on their ability to go to school in this age group or to work, and it impacts on the really impact of the disease. It may have neurobehavioral impact as well. Atopic comorbidities, which include our traditional asthma, allergic rhinitis, and conjunctivitis. Other comorbidities, higher rates of bacterial, viral infections, fungal infections, the mental health effects, some conflicting evidence, but some positive evidence impacting cardiovascular disease with atopic dermatitis. Impaired quality of life, obviously it can impact choice of activities and activities. And then schoolwork productivity, whether patients are going to school and how effective they are in school or work situations is very much influenced by their degree of atopic dermatitis. We know that sleep burden is significant for patients and families. This data shows that parents report 68% of their children having sleep disturbed. This is in 0 to 6-year-olds, so for here we're looking at the 6-year-olds, so to speak. Children were co-sleeping very commonly in the younger age group. Parents reported being bothered by co-sleeping, and 61% of parents reported their sleep being disturbed by atopic derm. There's a variety of studies that have shown impact even into adolescence on maternal sleep patterns in atopic dermatitis. So we know that the impact of active eczema impacts the patients themselves. There can be emotional distress and bullying, limitation activities, behavioral problems, sleep disturbance, and in caregivers, exhaustion and treatment-associated costs, which include the burden of topical care. Now, this is, of course, associated with the severity of the disease. So the mild patients, there's generally less of this, but don't not assess it. But once we hit to moderate disease, it's really quite significant. There is a very well-developed literature looking at physical and mental health effects, especially anxiety and depression in our moderate severe patients with increased risks, as well as increased risks of depression, beyond depression and anxiety, of ADHD in several studies. But let's move over to management of atopic dermatitis, because in clinical practice, that's really the punchline, and there are a variety of different algorithms that we use to discuss the disease. I thought it's reasonable. This is sort of a step-up care algorithm that's adapted, I say liberally adapted, because it was changed by a few people over time, including me, coming from Mark Bugunevich's article. But it basically starts with the basic principle that of mild and moderate with step-up therapy and then moving on to severe. I want to highlight mild and moderate. Obviously, that's what we're talking about in our 6 to 17-year-olds for this talk. Basic skin care is the standard, good skin care, liberal moisturizer use, avoidance of triggers or irritants. If you have mild disease, generally topical corticosteroids to inflame skin, and whether you use 2 weeks to get started, and then some people will then decrease their frequency to Q day and then go to twice a week beyond clearance, or if you do a treat for 1 to 2 weeks and 3 to 7 days beyond clearance, as it says in this particular algorithm. Those are standard methods. You can consider use of Crisaborole or TCIs as substitution for topical corticosteroids, either to delicate skin areas or instead of topical corticosteroids. But when we step up to moderate disease, basically if your people are still symptomatic, and they're doing the basic management, but they're having persistent or more frequent flaring disease, then you see the light blue on the bottom. You're applying topical corticosteroids, basically the same approach, but then you really want to have a standard maintenance therapy. And I still push the concept of proactive therapy or maintenance therapy with topical corticosteroids, TCIs, or topical Crisaborole. And this is really trying to get long-term disease control. And that's something that we want across the spectrum of care. Now, I'm going to quickly review the standard topicals, just highlighting where we're at in 6 to 17-year-olds. And the answer is topical corticosteroids. Obviously, a mainstay of therapy in this age group for mild to moderate disease. There's variations in terms of whether people start with lower potency topical corticosteroids or mid-potency topical corticosteroids. The age of the patient in this age group matters. So a 6-year-old with mild to moderate disease, I'd probably start with a moderate potency topical corticosteroid. The older the patient is, the more I'd have a tendency to be more liberal with stronger topical corticosteroids. And the more lichenified, thicken the patient, the more I tend to use more potent topical corticosteroids to get the patient under control. Maintenance therapy with topical corticosteroids is totally appropriate, very commonly once to twice a week to areas that commonly flare. The calcineurin inhibitors are steroid-sparing agents. They can be used for delicate skin areas. You're well aware of their use in their practice, but realize that the 0.1% tacrolimus is indicated greater than 15 years of age. So in the older age group, some places you can get it earlier as needed, and guidelines allow you to use either tacrolimus at different age groups. But the prescription patterns, the prescription guidelines from the FDA relate that only 0.03 should be used for up to 15 years of age, and the 0.1% after that. Topical Crisaborole is a newer alternative as a non-steroidal topical. It's a PDE4, really novel non-steroid agent, and this diagram just basically shows that PDE4 influences cyclic AMP consumption and may be anti-inflammatory. There's no limitation on the time course of use of these agents, and this can be useful in mild to moderate disease. That's where it has its specific approval, and the safety studies looked quite good with a topical Crisaborole. This was a 48-week safety study, which was post the phase 3 study. And you can see the age group included children that we're looking at in this particular talk, 349 to 17 years of age, as well as the adolescents. very low frequency of treatment-related adverse events, no differences in the younger age group, so relevant to this, it appeared to be quite well tolerated and safe in the study. There was no differences in adverse events over time, so no issues of like accumulation of problems or any immunosuppression topically with its use, and no safety signals in either the vitals labs or infections of neoplasm and up to the 1-year study with this agent. There are some topical agents that are in development. The time of recording this, there are some JAK inhibitors. We'll come back to that more in discussing systemic agents briefly, but the JAK inhibitors target different JAK anti receptors. So there's a pan-JAK inhibitor that's being developed for both atopic dermatitis and chronic hand dermatitis, ruxolitinib, and then delgocitinib. And then there's a novel aryl hydrocarbon receptor agonist called tapinarof. These will be a while yet before they may become as alternative topical agents. The big summary is 6 to 17 years of age, most patients can be managed for long-term disease control with topical care, but not all. But the messaging for topical care is to treat to minimal rash, minimal pruritus, and minimal sleep disturbance. And then long-term disease control is the goal. And the reason why that's important is that if you're not getting that, then even in the mild to moderate group, of which some of them are moderate, you may need to step up to disease care that's more aggressive, and those patients who have moderate severe, that's you don't have long-term disease control, you're not hitting these goals, then it's appropriate to step up. So when's it time for either photo or systemic therapy? The answer is if the topicals used appropriately aren't working. This is an algorithm that actually goes through when's it time for systemic therapy, and the answer is moderate to severe disease, which we'll discuss more in another talk. But here in this talk, we have our moderate patients. So you have a patient with moderate disease. They haven't gotten better. It's impacting on their quality of life. They've been well educated. They've done an intensive topical trial and done it correctly. You've considered other alternative diagnoses. Infections have been managed. You think about allergic contact dermatitis, but you don't think that's a big issue or they've been worked up. You consider phototherapy, and then if that's where you're at, you should consider the step up to systemic therapy. Systemic therapy has all kinds of changes that's happening in the field right now, and I think that there's an incredible revolution in systemic therapy for moderate patients as well as severe patients. So, but start off where we're at, which is looking at particularly our mild to moderate patients, 6 to 18 years of age. And for this discussion, I'm discussing the moderate patients because those are the ones who can make it into this algorithm. So moderate disease, 6 to less than 18 years of age, the issue is that we haven't had specifically approved therapy. So phototherapy doesn't need specific approval. It can be an option in this age group. If one has availability of UVB, that's something to be considered, especially for a mild or moderate patient. That might be a fine approach. But our traditional systemic agents, cyclosporin, azathioprine, methotrexate, mycophenolate, are not approved for atopic dermatitis, and they are used. Cyclosporin generally used more as rescue therapy. And none of these agents were very commonly used in the United States for even our severe atopic dermatitis patients. When we did a survey of what systemic therapies were being used a few years ago, methotrexate was the most common, cyclosporin the second one, occasionally systemic corticosteroids. They were used most commonly not in the hands of specialists, and they are approved but not advised, and people still use them occasionally for rescue therapy, so to speak, but it's not a long-term disease strategy. But of course, there's been a shift over. Now we have a specifically approved agent, dupilumab, which is approved 12+. So for this discussion, not yet approved 6 to 12 years of age, but that's on the horizon, and depending upon when you're listening to this talk, that may be the case already. But the 12 to 17-year-olds are now in an age group where dupilumab is approved for essentially atopic dermatitis that you're otherwise unable to get under control with topical agents. And we'll discuss that in more detail. But remember, in summary, our traditional systemics, methotrexate, most commonly used in the U.S., but still uncommonly used. It's not specifically approved in the U.S. Basically, this is a highly evolving area of clinical work. Our psychology of when to treat our moderate patients who haven't come under disease control is much more aggressive now than it used to be. But one should understand that the decision to use any of these agents, there's a variety of factors which include the general health of the individual, also the duration of therapy, because for instance, if we're going to use a biologic agent such as a dupilumab, we're generally going to plan to do that for 6 months to a year to get started, because with a biologic agent, you don't want to stop and start the treatment because of the concern that you may lose the efficacy over time. There may be the development of drug antibodies which can influence this. And this may be something that's a little bit different with some of the oral JAK inhibitors, a different kind of systemic agent moving forward. So our revolution is happening in systemic therapy. Dupilumab, as of March 2019, is the first FDA drug approved for adolescents. So we're talking 12 to 17 in our age group here. You notice the dosing is dependent upon weight, with an initial loading dose and then Q2-week dosing. Can be used with without topical corticosteroids. And studies have been done 6 months to 12 years of age, and it looks like that 6 to 12-year-olds are being handled as a particular group for approval, and as I said, could be approved at the time you're listening to this or about to be approved, but that's the expectation going forward. Further discussion of dupilumab I'll leave to a different discussion in the moderate to severe patients. But I did want to discuss the evolution of other systemic therapies. Oral JAK inhibitors as well are going to be very interesting agents for atopic dermatitis. You see in this diagram that there are basically 4 receptors, JAK 1, 2, 3, and type 2, and basically these are important receptors that influence on signals that then go within the nucleus and impact on transcription of a variety of cytokines. And the punchline is that different receptors will have profound effects on inflammation, but not with a generally gross immunosuppressive effect, or more importantly, a more selective immune-mediating effect that can impact on cytokines that are highly important in atopic dermatitis. These will be oral agents. There probably won't be a use of these agents with limitation of time course. What I mean is that with the biologic agents, we generally will be doing longer-term courses. With the oral JAK inhibitors, we may be treating for a year or 6 months, but we could be using 3 or 4 month shorter course treatments as well. Anything I say about these drugs right now, they're in development, they're well along the way, none specifically approved at this time, but you should be aware that these targeted agents can be very helpful in the care of patients we otherwise haven't driven to good disease control. And what this chart shows is that this is an incredibly active field, that the systemic therapy development for atopic dermatitis is this fascinating time period with both other biologic agents targeting different elements of the cytokine or immune profile, in addition to the IL-14 dupilumab, and then this development of these small molecular agents, including the JAK inhibitors, which are very exciting in terms of their potential utility in atopic dermatitis as well. Many of these are being developed either as adults first, although some of them are quite exciting, such as aprocitenib and others where they may be developing it at age 12. onward. So we will see these hitting the age group of this particular discussion probably within the next year or two. So putting it together in our mild to moderate patients, 6 to 17 years of age, the desire is to treat for the patients to be essentially clear of rash with good maintenance care, avoidance of triggers and irritants. Use intermittent topical anti-inflammatory medicines as needed, but if there's persistent, frequently recurring disease, consider maintenance anti-inflammatory regimens, so-called proactive disease. As we get more moderate, we want standard regimen building with maintenance disease to the point of long-term disease control. And if this cannot be established with topicals, step it up. And step it up to systemic agents. We will have more agents in this armamentarium that will allow us to really more effectively treat our patient's disease and minimize the impact of the disease on the individual and on the family. So thank you very much, and hope this was a worthwhile discussion of how we take care of our mild to moderate patients, 6 to 17 years of age.